Welcome. We are here interviewing one of our experts. I love doing this because everybody has a specialty and expertise, a thing that makes them super unique. This is Dr. Reid Nellis. He owns Minnesota Movement over in Excelsior. He is one of the doctors that we love referring to. He is a fellow DC. So believe it or not, even in the competing world of DCs, we like to refer patients to him. So without further ado, I would love to hear more from you, Dr. Reid, about who you are, what's your why, and then we'll dive into some other questions.
Yeah, so first of all, thank you for having me. I love the idea of everybody's an expert. Like one of my life mantras, and this is not the question that you asked, I might go on longer than you want to, but is that everybody's better than you at something, right? Like I think we can always learn from somebody in something. So even though we are competitors in a sense, we do get along and we do have our niches that we specialize in and we're experts in, right? So my why is I became a chiropractor because first and foremost, I'm a human, a husband, and a father, right? And I think being able to relate to people on that terms, not so much as a diagnostic terms, allows us to be kind of unshackled by diagnoses and things like that. Therefore, we can just think of people as people, right? If that means I get to be a shoulder to cry on, or we get to go through rehab and exercise because your ankle hurts, and the only way out of that is you doing those reps. That's what I get to do. My why, I've gone through, dare we say, the ringer. I've had over 42 broken bones. I've had 9 concussions. I was in a coma for 7 days, ACL, MCL, et cetera. So I've learned through the medical model that we sometimes need that shoulder to cry on, right? We sometimes need, dare we say, not necessarily outside the box thinking, but on the very fringes of that box thinking, or expand that box to a bigger box. And that's what I'm able to provide, or I hope to provide with my patients.
I love everything about that. I want to dive into the coma, but we're not going to here. It's
It was
today.
medically induced. Wasn't exactly flashy.
Still, that's intense. We're going to dive into you not taking insurance because it's one of the things that makes you really unique. Also, why you're able to deliver the type of care that you do, and very similar to what we do in cash. Tell me why.
Why? Because I want to work for the patient, right? If their goal is to do X, Y, Z, play with their kids, throw a baseball faster, play hockey, whatever it is, sometimes we find, especially with these complex cases, that insurance only pays for a portion of that. And as much as I like helping people, I also have to keep the lights on and run a business and have a life and things like that. And what we find through, if I was only taking insurance, is that sometimes I'm shackled by what we can do. And the insurance company's goals is only to get that person slightly better or out of pain. Well, what if they get out of pain really fast, but performance is their goal, right? Sometimes reimbursement rates don't pay for that at all. And then it kind of leaves me thinking like, well, I feel like I'm doing a disservice. Like we're not actually making these people best. We're making them better, but just not best. And there's nothing wrong with taking insurance. As a matter of fact, I sometimes find it cheaper for somebody to come in because I don't do treatment plans. If you come in on a Tuesday, I might not see you for a month, depending on what's going on. If you got a month worth of exercises that you need to do, I might give you those and say like, hey, I want to see you in a month. And if you're only paying $120 for that one session, that's $120 a month. That's often a lot cheaper than coming in 3 times a week for a $20 copay, for a month kind of thing too. So
I like that you referenced it that way. That leads me into your time sessions. Tell us what your treatments look like time-wise.
yeah, so kind of on that vein that I just mentioned, like our first session is always an hour, right? It takes us a long time to figure out what's going on and why that's happening. One of our kind of trademarks is fix the why. Like dealing with what's happening is pretty easy. If it's just pain, I can't provide this, but like, hey, let's take some high dose drugs. You're not going to feel anything. Now, I'm not advocating for that one bit. Pain is actually relatively easy, but it's a what. Why you're feeling pain is a different story. And so having that hour to figure out why this is happening, and then having the remainder of that time to figure out how to address it, whether that's exercise, whether that's manual muscle therapy, adjustments, cupping, red light therapy, any modality that we can utilize within that first hour. Subsequent visits are anywhere from 20 to 90 minutes long. Obviously, there's kind of a bell curve there. Most people don't do 20, most people don't do 90. It's usually 30, 40, 60 minutes, somewhere in between there. That gives us enough time to go through all of those facets of what we think is our version of care. We like to utilize what we call a tailored program, right? So your biceps tendonitis is completely different than your mother's, brother's, sister-in-law's, uncle's tendonitis. No matter how much you see on Google, like this is the fix for it, it doesn't always work for every case, right? So finding that approach that we can tailor, again, to somebody's situation takes time. Another reason why we kind of choose that time is the more time we spend in one session. For example, like I have a patient driving in from Hutchinson today. Do they want to drive in from Hutchinson 3 times a week or even 2 times a week or even every week? Probably not. So she's coming in for 90 minutes because we can get a lot of work and education done in that time. And now maybe she doesn't come back for 2 weeks or 3 weeks or 4 weeks or something like that.
Mhm. That's amazing, and worth the time, like you're talking about. Uh, in regard to the type of care, then, can you talk more about the movement-based care? Because you do a ton with movement. I want to know a little more about that with patient care.
Yeah, so my kind of joke is like we primarily work with athletes, like looking behind me, like there's treatment rooms, other side, treatment rooms and everything like that. We have a big space for rehab. My joke is that if you poop, you squat, and therefore you're an athlete, right? On that vein, most people didn't get hurt on a table. You're probably not going to get fixed on the table too, right? If you hurt yourself doing something athletic, well, the answer, the solution is probably something athletic to combat that, right? If we find a movement habit or a pattern that's aberrant or wrong, right? For example, let's say I'm squatting and my knees are crashing in. Well, I can do as much as we can do on the table to help be a catalyst to making that change, right? Kind of opening a window of opportunity to making that change. But ultimately, in order to get stronger, you have to do the reps. Like I can't squat 2 by 10 and then have those strength gains transfer to the patient, right? So in that movement space, figuring out what ideal movement looks like. And I'm not a big fan of like perfect posture, or perfect position, or perfect squat form or anything like that, but rather what your strengths and limitations are, not diminishing your strengths, but increasing those limitations that we have capacity for better movement.
Well, and that kind of brings me into the complex cases, because that's one of my favorite things about listening to you. You're capable of looking at the individual, the complexity of the situation, and really fine-tuning their care to cater to them. Do you have any specific cases you want to talk about, or just elaborate on that?
I mean, my favorite complex case is not actually that complex. It was just a lady who got really wine drunk and decided to dance on a table listening to Garth Brooks, and she broke both her arms. So,
Who wouldn't do
um,
that for Garth Brooks?
what's that?
I would do that for Garth
I
Brooks.
would gladly do that for
I,
Garth Brooks, and I've been to 3 of his concerts. Yeah.
I've only been
Um,
to one.
but those are kind of like the cases that are pretty straightforward. She broke both of her arms. We're working on rehab both arms, right? Almost occupational therapy at that standpoint. But complex cases in the sense where, like, let's imagine we have a baseball thrower and their right shoulder hurts. The right shoulder hurts, and they've been to all these other providers. They've had PRP. They've had surgical consults with MRIs and X-rays, and everything says it's normal, right? What we find through literature, and this kind of backs us up, is that anywhere up to 62% of cases that we see walk through our doors, chiropractors, PTs, and MDs, are what we call MUSs, medically unexplained symptoms, where their shoulder hurts, but there's no diagnosis that we can affirmatively put onto their shoulder pain. And what we find is like, hey, maybe their shoulder hurts because their opposite hip is limited in mobility, right? And the victim culprit side of things, we need to figure out through assessment and then therefore address that if we get their hip better, maybe their shoulder doesn't have to compensate so much as they're throwing and work too hard or work too little or things like that. So I love looking at, I always joke like on my business card, I want to put like Reid Nellis, puzzle putter togetherer. Like I love building the puzzle and figuring out the whole picture of, the system versus parts approach. Like the entire system works in conjunction. A single isolated part only has its action and job. And if it's forced to do a different action and job, too much or too little of, we're going to have problems somewhere else down the line.
That's amazing. That's our time. That was awesome. Thank you.
Of course. Thank you for having me.
See you later.